So rhabdomyolysis, or rhabdo for short, okay? So rhabdo is when you have a spillage of myoglobin into the bloodstream. And where is myoglobin at? It's in the myos, yeah. So it's in the muscles, right? It's not just smooth muscle or cardiac muscle, it's also found in skeletal muscle, right? So this is a skeletal muscle, a muscle that's attached to a skeleton, that's why they call it skeletal muscle, and it is going to be a spillage of these skeletal muscles for some reason, right? So, you know, rhabdo means skeletal, by the way, so, or striated or something like that. So you got striated muscle breakdown, right, or lysis. So it's rupturing because of, let's say, seizure activity, right? So we got some seizures happening, and that could be a reason for our for rhabdo. Okay, I thought I lost it, but yeah, seizures on here as well. Okay, and then it could be something like just getting too much propofol. We talk about the complications of propofol. Is it could lead to propofol-related infusion syndrome. Usually when you're like more than 40 mics per kilo continuous for like more than 24 hours, that puts you at risk of propofol building up and building up, causes lactic acidosis, and it also causes a rhabdomyolysis, where there's spilling and opening up of all these little skeletal muscles, and all this stuff is spilling into the bloodstream. Okay. What are some other causes? Statins. Statins damage your liver. They also damage your muscles, right? We pointed out a Achilles tendon rupture, but it also can rupture your muscles as well over time. So someone who has myalgias or muscle pain with their statins, that's a kind of red flag. We should be checking your levels to see if you have a rhabdomyolysis. And unfortunately, myoglobin levels aren't very specific. They fade away. You can't really detect it. It squeezes away, just like lipids with lipase, right? And bilirubin. So it just squeezes away. So what we can measure is what else ruptures out of the muscles is CK, right? CK is creatine kinase. So creatine kinase is inside these muscles here. I thought I had it here as well. All right. So CK. This is on the muscles, it goes into the bloodstream, and we can pick up CK levels or creatine kinase levels. All right, but what else besides statins and seizures and propofol that might cause a muscle breakdown? There's all genetic reasons, and that's more like pediatric reasons, maybe into adulthood, but really what we're going to see in the ICU, maybe some E2 withdrawals and seizures. All right, someone who has crush injuries and trauma is very common to have rhabdomyolysis as a concern. Also, it's considered a trauma as a fall, but someone who's fallen and can't get up, right? So they're found down. So whenever you hear someone says found down, your next question is what's the CK? Because if they're found down for more than 2 hours, or it's been 2 hours or more, they're at high risk for rhabdomyolysis. Right? So if someone's found down and they have an acute kidney injury, like the creatinine's elevated, it's like, well, why was that? Do they have underlying kidney disease, or was it rhabdo, which is an acute process that we have to make sure is not going to get worse, because it can be deadly. Okay, so infection, sepsis disrupts all organ systems, including muscles. All right, extreme physical exertion. So you have people that like to work out, and then like they want to work out extremely a lot, and they'll eat all the creatine powder, not creatine kinase, but all the creatine powder, and they'll overdo it. Right. Heat exposure, combination with that. So if you're at Venice Beach and you're working out in the sun, that's going to put you at high risk for rhabdo. Okay, and then we talked about being found down. There's some neuro disorders. There's seizures right there. All right, so seizures. And then there's reasons why we don't know. We don't know why they went into rhabdo. We'll try to figure it out, but sometimes we don't know. All we know is that the CK levels have risen. Right, so CK levels are high. Therefore, that's puts you at high risk of rhabdomyolysis. That's really the only reason why CK will be high enough like this. And CK levels that are like greater than 1,000, greater than 5,000, 10,000, 15,000, right? CK levels might be marginally elevated, like 200 or something. But when it starts getting more than 1,000, that's when you think, whoa, shoot, that's a rhabdomyolysis process. Okay, so. What else about rhabdo? So the myoglobin is spilling and spilling and spilling out of these muscles, right? And it's going to clog the kidneys, right? Not only does it clog the kidneys' nephrons, but it also is toxic to the nephrons, right? It literally damages the nephrons and makes them start sloughing, and leads to a clogged and damaged and ischemic nephron, which is called what? What's that called? Acute tubular necrosis. So ATN is a result with that, with a rhabdomyolysis. So it clogs, reacts to the nephron, is directly damaging, and causes an ATN, right? So what is creatine kinase in the first place? Why is it around? What's it for? Well, if you go to a, like 24-hour fitness, you go to a fitness place or you go to a vitamin store, they're going to sell you creatine, right? You will make your own creatine, but if you, take it by diet, you'll have more storage of creatine theoretically, and then you're going to use that creatine, and it's a quick energy source, right? Glucose is a good energy source, but it's not. It takes a while to break down glucose during all 21 steps of glycolysis of the Krebs cycle to finally get ATP, right? So creatine is going to be made into creatine phosphate. Remember phosphate, ATP, right? The P is phosphate. It's a quick energy source, so it's immediately available for when you have to run away from a bear, when you have to react and do things, right? And then at a specific rate, you're going to start breaking this stuff down and you're going to get creatinine. So this is where our creatinine comes in play, right? We mentioned that everybody makes creatinine. It's a waste product of our muscles. If you have more muscles, you're going to have more creatinine at baseline, right? And your muscle mass does not change overnight. Even with a rhabdomyolysis and you rupture all your legs because you had a crush injury, your creatinine level is not going to change because of muscle mass change. It will change because of ATN. But so creatinine is a very, very stable number, and it's always, deposited or urinated out at a constant rate, and it's also a certain percentage of it is only pushed out. So we know based on our checks that there's only be a certain creatinine level for every person, right? And if a person has a lot more muscle mass, they're gonna have a baseline creatinine that's higher versus someone that has a less muscle mass, an older person or younger person, or a liver cirrhosis person who's cachectic. Okay, so all this myoglobin will start reacting with the tubules, and then you'll start peeing out Coca-Cola colored, tea-colored urine. So when you ever hear tea-colored urine, there's usually 2 or 3 things at tops that it could be caused by, right? Most common is going to be your bilies elevated. You got gallstones, right? Your liver is making bile just fine, but it's not able to squeeze it through the biliary tree down into the GI tract, right? So all of it backs up, and you get a bili spilling into the urine, and you get tea-colored urine. That's what your stool usually is tea-colored or brown, right? And that's what usually your liver is able to deposit that through the biliary tree, and you're able to stool out the brown stool, right? But here it builds up and builds up and builds up, and you pee out bilirubin stool, or bilirubin stool, no, you pee out brown urine or tea-colored urine, okay? And then rhabdo, that's our other reason why you'd have tea-colored urine, right? So you're going in and you're doing your assessments, and you see tea-colored urine, you're like, shoot, what's going on? So if they have a elevated bilirubin, how would you know? How would you know the gallbladder's at fault? You would assess. You say, sit up, please, and you do a Murphy sign, all right? Or what else could you do? You could do look at the labs, and you could see what? AST, ALT might be elevated, but what would definitely tell us that we have a bili involvement would be, we have the T-bili would be elevated, the bilirubin would be elevated, and also the alk-phos. Those 2 things tell us that we have so down here, sorry, so for bili stuff, right? So T-bili and alk-phos, right? Alk-phos. Those are your key elements that tell you, oh, that's a bilirubin or a biliary or chole pattern, a cholestatic pattern. Okay, and then rhabdo has the following labs. Has a creatine kinase, that makes sense, right? CK is elevated, right, due to its spilling, and it's 5 times the upper limit of normal, so greater than 1,000 is going to be a problem. All right, so CK greater than 1,000 is definitely a high-risk patient, right? But what is more high risk? Greater than 5,000, right? That is a much higher risk patient. And then 10,000, 15,000, these are really high CK levels, and it's indicative of muscle breakdown. Our muscle is spilling all of these enzymes and other stuff into our bloodstream, right? So what else is spilled from muscles? What's an element that's in every single living cell in the body, including plant cells? And sometimes you have plant cells in the body if you eat salad. Leafy greens are high in this. K, right? So it's potassium, right? So potassium is going to spill into your bloodstream, and your K is going to go up, right? So you're going to get hyperkalemic. So K goes up, creatine kinase or creatine CK goes up as well, because it's spilling into the bloodstream. And also the phosphate that's there is spilling in the bloodstream as well. And when phosphate comes out, right, who else is going to come out to play? Who loves phosphate? Calcium does, right? So calcium less phosphate is gonna start hooking up, right? It's like it's like the Navy ship is just docked at the yard, and all the phosphates coming out, and everyone's getting hooked up, and then there's gonna be less free calciums around, right? So all the calciums are gonna go down. So you're gonna have a low calcium with this, right? So low calcium will be a consequence of phosphate spilling everywhere, right? And then AST, ALT, we know that one of those is found in liver, or both of them are found in liver, but one is found only in liver. Which one is only found in liver, AST or ALT? ALT, L for liver, is only found in, ALT is only found in liver. But AST, yes, it's found there, but it's found in more amounts in muscles. So if you have muscle damage, you're going to have an AST elevation. You might think, oh, shoot, the liver is damaged. But we know if the AST is greater than ALT, it could be alcohol, statins, or Tylenol could be the reason, but it could also be rhabdo, right? So rhabdo is you have AST elevation, K elevation, phosphate elevation, creatine kinase elevation. If you can measure it, myoglobin elevation. The only thing that's low is what? Calcium, right? So calcium is our only one that's the low one there. Okay, and then so we got over here is our little fishbone, right? So our creatinine's high because why does the creatinine go up? Was creatinine spilled? Creatinine? I thought it was a creatine. Which one was it? It was creatine kinase was spilled, right? But why did the creatinine go up? What do we say happens? Good. So myoglobin is going to start clogging the kidneys, right? Myoglobin over here is clogging the kidneys, all the little myoglobin molecules. It's like hemoglobin that's been hacked, and it's just a hemoglobin that's only for muscle cells, right? So it spills out, and it then clogs the kidneys, right? And causes acute tubular necrosis. Therefore, the creatinine goes up, right? So here's our K going up. Our calcium is going which direction? Calcium going down over there, and these aren't on the standard chemistry, so we have to add a calcium, mag, and phos. Mag's not going to be affected, but the phos will be elevated, calcium will be low, right? And of course, we add a liver panel, and we're going to see what in the liver panel? Increased AST. Very good. Okay, so other things to consider. Yeah, we're going to get an AKI, right, due to the cell breakdown and such. You might get uric acid buildup, but it's the other ones are really going to seal the deal when you have a creatine kinase elevation. The only reason I bring that up is because there's another condition where cells just start rupturing over time. It can happen with like leukemias when you have rapid turnover of cells, or it can happen with chemotherapy. That's called tumor lysis syndrome, right? And it has a similar pattern where you have phosphate spilling out because that's inside the cells. You have K spilling from all those cells that are dying, and you have calcium going down because it's bind with all the phosphorus, and then we have uric acid and LDH, which is kind of, yes, that's very, very unique to tumor lysis syndrome where you have this rapid turnover of cells. So they have similar labs, but what the tumor lysis does not have is a change in the UA, right? So on the UA, the myoglobin is made of what? What is similar to hemoglobin? It's made of what? It's made of iron, right, and protein. So, but the iron piece is going to react on our UAs, right? And UA is going to think you have a hematuria at play, right? So you'll have heme positivity on the UA. So on the UA here we have, so you got blood, and then you do a little count. You send it to the lab, they do a little count and say how many RBCs are there. They're like none, right? Less than 5 is none. So it's like, well, shoot, is that hematuria or not? It's T colored. That's close to red. I don't know. Is that bloody urine or not? Right? But it's not. It's just the myoglobin reacting on the UA strip, right? It's saying you have blood present, but it's not no blood cells. So that's one of the key things with rhabdo when you look at the UA is that there's heme positivity but no RBCs, right? Because you could be heme positive with RBCs. That could be like with your glomerulus is breaking down and spilling RBCs, right? And in that case you would have elevated RBCs and you would have heme because RBCs have what in it? Hemoglobin, right? So that's the idea with looking at the UA as far as diagnostic tests are concerned, right? So how do we fix this? What are some ways to fix it? So we're going to give a lot of fluids, but not to a point where we're making them hypervolemic because that's going to make our creatinine even worse, right? So you just give 2 to 4 liters. It depends because if you give more and more fluids, where's the damaged part of the body? It's the muscles, and those muscles are leaky and they're going to get infiltrated with a whole bunch of fluids, right? Fluid will move into the injured muscle. So the fluids of choice, obviously not normal saline because this is your hyperkalemic. And what happens with hyperkalemia? You get what kind of ABG derangement? You get acidotic, right? And giving normal saline is going to make you more acidotic. So the best thing to do is to give a bicarbonate infusion. So usually it'll be on a bicarb drip, right? So again, when you get reports and they're on bicarb drip, it's usually for AKIs, right? That's usually the reason why we're giving it, to prevent them from going to need dialysis. And it could be rhabdo. So those are the kind of, and rhabdo ironically could cause an AKI too. Okay, with the CKs like greater than 15K, you probably need dialysis. So there's a little quick scoring system here, McMahon scoring. You don't have to memorize this or anything. You just look it up when you do have a rhabdo patient. It tells you how sick they are. It tells you what their mortality is, right? So mortality is pretty bad if you got more than 6 points. And this should make sense, right? You got age greater than 80 with someone with rhabdo who's found down for 6 hours, and they got acute kidney injury, you got organ damage. Well, that's already 3 points right there. You only need 6 to be a high risk patient, right? Creatinine going up, well, because they have an AKI, right? And calcium less than 7.5, well, we know that because calcium goes down in rhabdo, right? That's the reason why I bring these scoring systems in there, because it's solidifying the lab results that we expect, right? And phosphate can be high or low.
Well, it's binding.
It is binding, but it's still spilling, right? Calcium was not spilling from the cells, so phosphates just keep coming. There's so many dockings of ships at the New York Harbor, right? So all the phosphates keep spilling onto Manhattan. So you're still going to have elevated phosphate, right? And yes, the calcium will get used up, right? And CK, this says greater than 40K. That's really hard to get 40K, but that does happen, and especially if they're down for a long period of time. If they have all these reasons, immobilization just in the ICU can put someone at risk, especially if you have like an ARDS patient who's like swollen and they're not moving them at all because they're so sick. That can just be the extra, not cherry on top, but extra, what's the word? Straw that broke the camel's back, right? But one of the things that can lead to a high score here, they're on statins, they got exercise induced, right? They got seizure activity, and the bicarb getting low, right? So bicarb will be low because they have an acidosis developing because of what process? Why are they acidotic? There's spillage of K, right? And K is getting exchanged with hydrogen, right? Because your body doesn't like high potassiums, because it's going to interrupt heart function, right, with a K, cardiac function. So it's going to interrupt cardiac function. Therefore, it says, hey, let's put you aside until you can pee it out. And then little they know they can't pee it out because the kidneys are clogged, right? So the K is going to go into the cells in exchange for hydrogen, and we're going to get metabolic acidosis. All right, so that's the idea with a rhabdo, is that we have this tea-colored urine due to several different causes. Common causes being seizures found down, right? They have heat exposure, hyperthermia. There's certain myopathies they might get. There's neuroleptic malignant syndrome for malignant hyperthermia, right? All these things can lead to muscle breakdown. And then we get our labs that we talked about, all right? Elevated everything except for what? What was not elevated was calcium. And the mnemonic there is pluck, from tumor lysis syndrome. You just kind of take out LDH and uric acid, so just pluck. All right, so but you can maybe add some plaque, maybe, so you get an AST elevation. Anyways, we'll come with a better mnemonic later. So, but you definitely get AST elevation more than ALT, because ALT is only found in the liver. The liver's not being damaged here. The liver's not being clogged with myoglobin. The AST is found in muscles more than liver tissue. Okay, so treatment, we're giving fluids, and the best fluids to give for this patient, especially any patient really, with metabolic acidosis is what? LR is okay, but we've got a better option. We got a bicarb drip, right? Bicarb infusion.